neurosurgeon at Brigham and Women's Hospital in Boston, Massachusetts. My primary interest is that of pituitary disease, and our goal here is to provide multidisciplinary care for patients who have very complex disorders that involve the pituitary gland and that often end up involving a very special type of surgery that we call minimally invasive endoscopic transnasal surgery for tumors that affect the pituitary gland, which lies underneath the brain, kind of just behind the bridge of your nose. Well, my journey here has been fairly complex, but I'm delighted to be here. It's a wonderful environment, great colleagues, and great collegiality. I started out at the Johns Hopkins Medical School in Baltimore, Maryland, and at the end of the freshman year I had a 10-week elective period and was lucky enough to get a grant from the National Institutes of Health and studied in a laboratory that was designed to look at brain tumors. And we did some of the very first work when I was just a freshman medical student on characterizing the enzyme activities, the metabolism of brain tumors. So that was very exciting, and I got to know all of the people who were working in neurosurgery and in neuroscience at that time. And from then on, it was just neurosurgery. So every summer I worked in neurosurgical laboratories, and I spent as much time as I could with the neurosurgeons and their patients, and was fortunate enough to do my surgical internship there at Hopkins and then my residency to follow that. That was a 5.5-year residency, and during that time I developed a liaison with the endocrinologist, learned about pituitary disease, and made that a focus of my surgical practice as I became a resident and then on the faculty at Hopkins, and then was recruited to the Mayo Clinic in Rochester, Minnesota. So I was there for 15 years, and that was a perfect time because the new techniques had been developed, new laboratory tests to analyze hormones had been developed, and I had lots of patients, and it was a wonderful environment in which to work. I went from there to be chair of neurosurgery at George Washington University in Washington, D.C., and after a period of time there was recruited to the University of Virginia to build a multidisciplinary pituitary center, which we did, and I worked there for quite some time, and then went to Stanford for a year and did the same thing there, built a multidisciplinary neurosurgical-based pituitary group, and then one day got a phone call from the chief here at the Brigham saying, would you like to come to Boston to do that here? And so I did. It's been almost 3 years, and it's been a wonderful experience, both scientifically and surgically and professionally. Well, most of the time, pituitary tumors are benign. So if you have to have something wrong with you, it's one of the best things because we have a really good handle on it. Unfortunately, there's a small percentage that are not benign, and they are what we call aggressive or even malignant pituitary tumors. And until very recently, we had absolutely no way of dealing with them. Surgery couldn't remove them completely, radiation therapy couldn't treat them completely, and we had no effective drug therapy. Well, along comes a drug called temozolomide that is being used for malignant brain tumors called glioblastomas. And we had the idea that perhaps pituitary tumors that were aggressive or malignant could be treated with that same drug. And so we did a small clinical trial in conjunction with investigators elsewhere, primarily at the University of Virginia, where I had worked before, and showed that we could treat about 60%, maybe 70% of these malignant tumors effectively with temozolomide. So once we saw the efficacy of it in treating patients, the next question was, does it work the same way as it does in malignant gliomas? And do we need to do the same testing of the patient to see if the patient's going to respond to the drug? So we mounted a trial and looked at the way the tumor itself protects the patient and the tumor against what we call DNA breaks. So what happens when chemotherapy is effective is it prevents the repair of breaks in the DNA. That's the the reproductive mechanism of the cell, so it can't reproduce and the tumor then dies. We studied that in the pituitary tumors thanks to a grant we received from the Brain Science Foundation. Couldn't have done it without it. And we studied a large number of pituitary tumors, both extraordinary and aggressive malignant, and showed that the same kind of analysis that we did for malignant brain tumors wasn't necessary for the pituitary tumors. That we could just go ahead and treat them with a pretty high anticipation of efficacy, and we didn't have to waste the time and the expense and the anxiety for the patient of trying to put them through some sophisticated testing for something that turns out not to be part of the mechanism of response of our pituitary tumor patients. So it's very exciting to know that we have the drug, that we can use it effectively, that we can do it without a lot of fancy, expensive, and sometimes harrowing testing. And I think it's made a big contribution to how we deal with a small but very important portion of the tumors that we see.